Alright, so right now we're going to talk about disorders of the middle ear, moving past disorders of the outer ear. We're at that tympanic membrane and into the middle ear space. So you remember the role of the middle ear is to take acoustic energy from the ear canal, amplify it before it gets sent to the fluid in the cochlea. So without our middle ears, it would be like we were hearing underwater, and you don't hear well when you're underwater. So the middle ears have a very important function to amplify sounds from the outer ear before they enter the middle ear. Any disorders of the middle ear cause conductive hearing losses. So the middle ear carries vibrations from the outer ear to the inner ear by transferring sound from the air to the fluid in the inner ear. And to do this, it has to overcome the loss of energy that would result when sound passes from one medium, being air, to another medium, fluid. So remember that from hearing science. It is transferring different mediums, so we need to amplify it. Here's a quick picture of the middle ear. We finished talking about the outer ear. Here's our air-filled space, aerated by the Eustachian tube, the tympanic membrane, the malleus, the incus, and the stapes. And again, it's an air-filled space. You have your three ossicles. So the three bones, the three tiniest bones in your body, combined to call the ossicles. Individually, it's the malleus, the incus, and the stapes. The middle ear is an air-filled space, very tiny, 1/2 inch high, 1/2 inch wide, 1/4 inch deep, separated from the ear canal by the tympanic membrane, connected to the nasopharynx, or the nose and throat, by the Eustachian tube. And that's why you visit an ear, nose, and throat doctor, I'm sorry, because the outer ear, not the outer ear, the middle ear, is connected to the nose and the throat through the Eustachian tube. So it's all connected. The space of your middle ear is similar to the lining of your nose. It's a mucous membrane. It's ciliated, which means it has some hair-like projections that help wipe it clean. So to keep the middle ear clean, these cilia will wipe debris down through the Eustachian tube, and then you swallow it pretty much, So any debris gets wiped clean by the cilia down through the Eustachian tube to the back of your throat. The Eustachian tube is on an angle. It is also ciliated. The top part is cartilage, the bottom part is bone. The Eustachian tube is usually kept closed, but when you yawn, when you sneeze, when you swallow, you open it. So if you have a moment, everyone just yawn. You can open your Eustachian tube. You feel it opening. So when your Eustachian tube opens, it's like you're bringing fresh air into your middle ear space. So you're aerating your middle ear by opening your Eustachian tube. In infants, the Eustachian tube is shorter and wider and on a more horizontal plane. And that's why they get more ear infections, because it's not on a vertical plane. So here's our Eustachian tube headed downward on an angle to the nasopharynx. So the air pressure in the middle ear has to match the air pressure in the external auditory canal. The pressures need to be equal on both sides. So the air pressure in the middle ear has to be the same as the air pressure in the ear canal so that the tympanic membrane can move at its best. And it's the Eustachian tube that helps keep that pressure balanced. So the Eustachian tube is very important in keeping the air in the middle ear at the same pressure level as the air in the ear canal. Now, when you go up on an airplane or when you go up on an elevator really fast, or when you come back down, it's the same feeling. Your ears feel very full. They feel like they're going to pop. They're not going to pop. What you're feeling is you're feeling a pressure difference between the air in your middle ear space versus the air in your ear canal. So, for example, let's say you're sitting on a runway. The air in your ear canal is at sea level. The air in your middle ear is also at sea level. All of a sudden, you take off. You go up very, very fast. The air in your ear canal is now at like 30,000 feet above sea level. It's much thinner. but the air pressure in your middle ear hasn't caught up. The air in your middle ear is still at sea level. So you feel this pressure difference where the air in your middle ear is sort of like bulging. It's so much denser than the air in your ear canal. So the tympanic membrane, it pushes outward and you feel this pressure. So to get rid of the pressure, what you do is you chew gum, right? Or you swallow, or you yawn, you drink something. You try to open up your Eustachian tube and air it out so that the pressures go back to being balanced. And then you feel better. It's the same sort of feeling when you're going down, but it's different. So let's say you're on a 3-hour flight and your ear pressure in your middle ear and your ear canal has evened out. And now it's time to descend. Again, you go down very quickly and you end up back at sea level. So the air in your ear canal is now at sea level, and the air in your middle ear is still at a pressure 30,000 feet above the sea. So now the tympanic membrane is pushed inward. It feels the same either way, and it's the same to fix it. You have to chew gum, open up your Eustachian tube, air it out to balance out the pressures. The middle ear is held in your mastoid bone. It's the bone of the skull that surrounds the ear. It's honeycombed with hundreds of little air cells that are lined with mucus. They are not ciliated. The mastoid is important. It's like a hard bone to keep the cochlea safe, and it also helps with bone conduction hearing. So you have 2 windows in your middle ear, and then there's a bony portion of the inner ear that extends into the middle ear, and that's called the promontory. And that separates the connection between the middle ear and the inner ear. Now the top window is called the oval window, and that's the window that the stapes footplate, the last bone of the middle ear, sits in, and the bottom window is the round window, and that has a thin elastic membrane that releases pressure from the cochlea. You have the 3 smallest bones in your ears. They're called the ossicles. The first is the malleus, and remember the manubrium, or the handle of the malleus, is embedded in the tympanic membrane. It kind of pulls the tympanic membrane up and on an angle. Then you have the incus and the stapes. The base of the stapes sits in that oval window. The malleus and the incus are tightly connected. The inward and outward movement of the umbo, that's the part of the malleus that's embedded in the tympanic membrane, causes the 2 bones to rotate, and this transfers a force, which results in the inward and outward movement of the oval window in the cochlea. Okay, so if you look at this picture, first of all, you see, I think this is a nickel. Look at how tiny this is. So we have the tympanic membrane. We have the manubrium, the first part, and the umbo sucking the tympanic membrane up. So that this bone is the malleus, the incus, the stapes. The stapes footplate, the base of the stapes, sits in the oval window. This is the cochlea over here, okay? This is the promontory. It's that little bone that comes in. We have the oval window where the stapes footplate sits. Then you have the round window, which has a membrane on it. So air waves get sent in here. They bounce out the tympanic membrane. These bones move. They amplify the sound in their movement. The sound gets, this last bone pushes in on the cochlea, the stapes footplate. As it pushes in on the fluid of the cochlea, down here, the round window releases the pressure. I guess that's the round window, okay? So push in, release, push in, release. And there's a membrane there to help release the pressure. So remember I said the role of the middle ear. It is an impedance matcher. It takes the sound waves from air and it brings them to fluid. In order to do this, there are 3 things that happen. So the first way that this sound gets amplified is by the area difference between the tympanic membrane to the oval window. So if you remember from hearing science, we have a force coming on this tympanic membrane, this big area that's being transferred to this smaller area. So a hammer to a nail, right? A big area to a small area. We have an increased amount of force. That's one way the sounds get amplified, the area difference. And you have a lever action of the malleus upon the stapes, the bones that are connected. And finally, there's a little portion of the buckling of the tympanic membrane also increases the pressure. The largest increase of pressure comes from that area difference between the tympanic membrane and the oval window. This results, so these three things result in an increase in pressure between the oval window 23 times would be if there were no middle ear system. So a 30 dB increase in sound provided by the middle ear. That's a lot. That's a very large amount. 30 decibels of sound increase from the air in the ear canal to the fluid of the cochlea by the middle ear impedance matcher. So the middle ear helps to compensate for that air to fluid mismatch based on the size of the tympanic membrane in relation to the stapes footplate, the lever action of the bones, and the buckling of the tympanic membrane. There are some non-auditory structures of the middle ear that don't really relate to hearing. You have the fallopian canal, so a portion of the facial nerve runs through the middle ear. You also have two very, very tiny muscles in the middle ear, and their function is still debatable, but we have a good idea what they do at this point. So they might serve as the protective function for the inner ear, stiffening the ossicular chain and attenuating loud sounds and potentially damaging sounds. But they're reflexes, so they're short. So, for example, if I were to bang a pot in front of your ear, the muscle would contract and it would pull the tympanic membrane up and sort of help not send the sound in so much, but at the end of the day, the sound is still going to go in, and it's a reflex, so it doesn't hold too long. So it's not a real protective function of the inner ear, but it's still pretty neat that that happens, and we use that in audiology, right? Remember the acoustic reflex test? That's what we spoke about probably 2 chapters before this. Another role of the middle ears, the middle ear muscles, they may serve to decrease the loudness of sounds generated within the head. Believe it or not, your body is a very noisy place. You've got, blood flowing through your veins when you're chewing, when you're speaking. All of these sounds are very, very loud, but they don't seem so loud to you. So maybe it has to do with the muscles of the middle ear not letting your middle ear transfer these sounds into your cochlea. The first muscle is the Stapedius muscle. When it's contracted, the stapes moves to the side and tenses the membrane of the oval window. Thus, it reduces the amplitude of vibration. This might help improve word recognition and noise by attenuating low-frequency components. It is innervated by a branch of the facial nerve. The other muscle is the Tensor Tympani muscle. When it contracts, it moves the malleus in a way that the tympanic membrane becomes tense. Both muscles are reflexive and bilateral. So if I bang a pot on your left side, your left muscles contract, and so do your right muscles. Okay? So it doesn't matter what side you come on, they'll both contract. Well, the Stapedius muscle is thought to move in response to sound. Okay, so it's mostly the Stapedius muscle. Any abnormalities or hearing loss in the middle ear are going to produce conductive hearing losses. So the outer ear abnormalities produce conductive hearing losses. Middle ear abnormalities produce conductive hearing losses. The worse the disorder, the worse the hearing. So the most common type of middle ear disorder that I'm sure many of you have had is called otitis media. So otitis, if you remember, is an infection of the ear, and media means middle. So it's one of the most common disorders of the middle ear. It produces a conductive hearing loss, an infection of the middle ear space, otitis media. It affects nearly 70% of children before they're 2 years old, caused by poorly functioning Eustachian tube, abnormalities of the cilia in the middle ear, and anatomic deformities of the middle ear. There are additional factors that influence prevalence, including age, so younger, race, some people who have rounder faces. For example, I remember on my praxis exam, Eskimos were more likely to have middle ear pathologies, and it has to do with the structure of their face. They have rounder faces. So their eustachian tubes would be more on a horizontal angle than a vertical angle. There are socioeconomic factors. A weak immune system will create ear infections, and cigarette smoke. Have you guys seen those very sad public service announcements where they have a little baby crying and crying and crying, and the baby's sitting on the floor with secondhand smoke around him? So here's the reason infants get more ear infections. Do you see this eustachian tube? It is horizontal compared to the adult eustachian tube, which is vertical. So when we were infants, we all had very cute round faces, and then as we grew into adults, our faces narrowed, and as our faces narrowed, the eustachian tube and it turned into more of a vertical angle. So for a child, if they get a cold, it's much easier for that child to blow the cold or the infection from their nose up through the eustachian tube into the middle ear space. It's harder for an adult, unless you have a really, really bad cold, to blow the cold from your nose up into your middle ear space. So otitis media is an infection of the middle ear space. It pretty much originates in the nose as a cold or a sinus infection. Ear infections are primarily a disease of childhood, but they can occur at any age. They are more common in winter, as we have more colds, more prevalence in men. Remember I said they're more common in Eskimos and Native Americans, and a major cause in childhood is tobacco smoke. It irritates the eustachian tube, and that's why children get more ear infections. Like I said, the infection will begin in the eustachian tube and travel up the narrow pharynx. It can spread throughout the middle ear cavity. It can be blown by a stifled sneeze or blowing your nose too hard. So you don't want to stifle sneezes and you don't want to blow your nose too hard. When the eustachian tube becomes infected, it gets swollen. That interferes with the pressure equalization between the middle ear, and it interferes with the cleaning action of the cilia. So here's an example of fluid in the middle ear space. Sometimes with ear infections, the fluid gets infected, and sometimes it's not, and a child will just have fluid in their ear. I'm sure you've heard that expression too. So with otitis media, medical treatment is important. You could get swollen negative type C tympanograms, or you could get type B tympanograms when there's a lot of fluid and the ear canal can't move at all. The tympanic membrane, remember I gave the example, it will become very red, it will become very painful if the fluid is infected. If the middle ear space is infected, the tympanic membrane will be bright red and painful. With a suppurative otitis media, the mucus may become filled with excessive amounts of blood. This is a very serious otitis media. The superficial cells will break down, and pus will accumulate, pain in the middle ear, body temperature, visibly ill. If it's left untreated, the tympanic membrane will eventually rupture, and it can invade the mastoid, the bone, causing mastoiditis, breakdown of the walls, separating the air cells, and meningitis and possible death. The winter when everybody was so concerned about Ebola, people in Africa were dying by the hundreds and thousands of Ebola. And Ebola was getting all this attention because, it was a virus and it was very scary. But I don't know the exact statistic, but every year I might make some much larger amount of children in Africa are dying of ear infections. So ear infections are a very serious problem in a number of parts of the world that don't have easy access to antibiotics. We can think about ear infections as no big deal, but for a lot of children, ear infections can be a very big deal if they're left untreated because, again, it's an infection in the middle ear, which is very close to your brain. And if it's left untreated, it can break down through the middle ear into the mastoid bone and into your brain. So every year there are thousands of children thousands and thousands of children that are still dying of ear infections. Ear infections may be chronic or they may be acute. So a chronic ear infection is one that's around for a long time. An acute comes on rapidly with swelling and redness and bleeding. It's like on faster, then it goes away. With ear infections, we have conductive hearing losses on the audiogram. The amount of hearing loss is related to the amount of fluid. So if there's a little bit of fluid, the child won't have a hearing loss. If there's a lot of fluid, like that picture, the child will have a conductive hearing loss. When you have a lot of fluid, you'll see a type B tympanogram. If you've got some fluid, you'll have an AS. If you have just a lot of negative pressure and stuffed up, you're going to get a type C tympanogram. Antibiotics are recommended for children with ear infections. They have to be followed very carefully. Sometimes doctors won't prescribe antibiotics right away because they're worried that kids get too many antibiotics, and they'll, wait to see if the body can beat it on its own and closely monitor the middle ear infection, and then decide if they need to go forward with ear infections. There is surgery, a myringotomy to remove the fluids of the middle ear space. There's an incision made through the tympanic membrane, or a mastoidectomy, where the mastoid bone is scraped. So for people born during the Depression, so I remember my grandfather had this, someone who had severe ear infection before they had antibiotics, the way that they treated it was they just scraped it out. They took out wherever the infection had gone in the mastoid bone, and there would be a concavity in the middle ear. So part of the mastoid bone would be removed, the part that was infected. And that was a pretty common treatment for severe ear infections back in the turn of the 1900s and the 19 teens and 20s. So a tympanoplasty is a reconstruction of the middle ear. After, let's say, there was a very severe ear infection, trying to put the ossicles back together, hearing improvement, varies. Negative middle ear pressure is a condition that could occur secondary to infections or allergies or, real bad sinus infections. It's a retraction of the tympanic membrane due to Eustachian tube dysfunction. So when your tympanic membrane is sort of sucked in, it could produce a slight conductive hearing loss. If let's say you were on a plane with a cold and you landed and your ears were just they felt so weird, that's negative middle ear pressure. And maybe you did have a mild hearing loss, but if you keep trying to open your ear canal and chew and swallow, you release that pressure. You could do the Valsalva maneuver where you pinch your nose and you blow up, just trying to get that Eustachian tube to open and aerate itself. A Patulous Eustachian tube is a chronically open Eustachian tube where things just sound silly. It can be not silly, they sound extra loud. They just sound different because Eustachian tube isn't closed. It can be associated with pregnancy and hormonal changes in body weight, use of decongestants, or stress. Serous effusion of the middle ear is a partial vacuum if left untreated. Then the normally secreted middle ear fluids may not properly drain out the Eustachian tube. So if there's an infection if there's fluid in the ear, that doesn't all get out. So the levels of fluid in the middle ear might rise. They reflect, usually results secondary to poor functioning Eustachian tubes. Decongestants could help restore normal middle ear pressure. So this might be, just because you have fluid in your ear doesn't mean it's infected. So this is just that fluid in the ear, and, I'm sure maybe you guys have nieces and nephews or cousins that have fluid in their ear, right? We've heard that example. Parents are very concerned about fluid in the ear and how it's affecting a child's language development. Fluid in the ear is sometimes treated with PE tubes. Maybe some of you guys had PE tubes. PE tubes stand for pressure equalization tubes. So when your Eustachian tube just isn't working correctly and it's not doing its job to aerate the middle ear space and to drain the fluid, a small incision would be put in the tympanic membrane, and a small tube would be inserted in like the lower edge of the tympanic membrane, so it's not going to be like dead center in the middle of the tympanic membrane. And the Eustachian tube has, not the Eustachian tube, so these PE tubes allow direct ventilation of the middle ear space into the ear canal. So they serve as an artificial Eustachian tube. They stay in place for several weeks and then they fall out naturally into the ear canal. So when the Eustachian tube isn't working well, otologist might put a PE tube in, small incision in the bottom of the tympanic membrane. This serves as an artificial Eustachian tube, so it drains the fluid out of the middle ear into the ear canal space. After a few weeks or months, the skin around this area is going to heal. As it heals, it's going to push the tube out into the ear canal. And you know, the ear canal, you might see it on your kid's pillow one morning. It'll come out on its own. Sometimes tubes need to be reinserted, right? So the kid has it for 3 months, the fluid comes back, then they have to get the tube back in. Another type of otitis media is mucus secretion flowing through the Eustachian tube in the middle ear space. If it's allowed to remain there, so if you get mucus in your middle ear, it's called glue ear. That's an old-fashioned term for an ear infection. If left untreated, it could really affect the bones, the muscles of the middle ear. So it has to be removed. If you can't get it out with antibiotics, if it doesn't treat it, they can suction it out. Moving past infections of the middle ear, we have a disorder called otosclerosis. This is a hereditary disorder that affects mostly women. It's a progressive disorder, and it's a conductive hearing loss in the bones of the middle ear space. So it's seen more in adults, rarer in children, more common in Caucasians, more prevalent in women than men, and it's more prevalent in women during pregnancy or menopause when they have hormonal changes. So it appears as a formation of a new growth of spongy bone over the stapedial footplate. So when this spongy bone grows over the stapedial footplate, the footplate gets partially fixed in the oval window, and that limits its amplitude of vibration. Symptoms include a bluish cast to the whites of the eyes. It's a bone disorder, so symptoms are similar to that of other bone disorders. People also complain that they're bothered by tinnitus. The hearing loss is slow and progressive. It starts in the low frequencies, and then it'll travel, kind of become flat to the higher frequencies. Because it's a conductive hearing loss, all you have to do is make the sounds louder for the person to be able to hear better. So sometimes when we're in noisy situations and people are talking louder, these people will be okay. You just have to amplify the sound for them to hear better. People that have otosclerosis are going to have a low frequency air bone gap. Remember, it starts in the low frequencies. There's going to be changes in inertia of the articular chain. So the bones aren't going to move as well. Around 2000 hertz, a Carhart's notch, you're going to see a change. Slow drop in hearing sensitivity. The hearing sensitivity gets worse as the fixation gets worse. It produces a flat conductive hearing loss. It can be treated with a stapedectomy, which is a removal of the stapes and a prosthetic is pushed in. Okay, so here's a picture. Here's what our normal middle ear should look like. This is otosclerosis. You see there's an extra spongy growth on the stapes footplate. So this spongy growth on the stapes footplate is affecting the stapes' ability to push in and out on the cochlea. So it can't move in and out of the cochlea so well because of this bony growth. So here's a stapedectomy. The stapes was removed and a prosthetic was put in. Creates a low frequency hearing loss, conductive hearing loss, low frequency to moderate flat conductive hearing loss. It's more common in women. There are other genetic causes of middle ear hearing loss, disorders that are associated with, or syndromes that are associated with the cheek and the jaw. Any surgery on a child to fix these genetic disorders, you have to wait until the child's a little bit older and more fully grown. Other causes of hearing loss could be skull fracture, so a bad car accident, fractures of the ossicular chain. These bones are very, very tiny. You can't just go in and repair them. It's very complicated to do. So skull fractures and whatnot might lead to a permanent conductive hearing loss. A very traumatic perforation of the tympanic membrane, a tumor in the middle ear, could be benign or malignant, polyps, vascular tumors, or a tumor called a Cholesteatoma. This is a pseudotumor. So, for example, let's say you have a perforation in your tympanic membrane that was caused by a Q-tip. So you perfed your tympanic membrane from the ear canal into the middle ear space. And there was some skin that got in there after the tympanic membrane healed. And the skin just sort of started growing on its own. And there was this sack of proteins and fats, and it just grew and grew and grew. And it sort of overtook the middle ear space. So rapidly growing, destroying the middle ear bones, destroying everything in its path. As it moves up and out, it can become infected again. Any sort of infection is not good in the middle ear space. So here's an example of a cholesteatoma. It's just this growth in your middle ear space that's, knocking everything out in its way. So it has to be fully removed because if it's not fully removed, it'll grow back. A facial palsy. So chronic otitis media could erode the bony covering of the fallopian canal, exposing the facial nerve. Could have no clinical cause. It could be related to the blood supply, a nerve, or a viral infection. Facial palsy, damage to the facial nerve, flaccid paralysis on one side of the face. This is called Bell's palsy, one-sided flaccid facial paralysis. It sometimes resolves itself. So if you can see in this picture, her face is a bit droopy on the right side. This would be Bell's palsy. So sudden onset of paralysis or weakness on one side of the face, making it difficult to smile or close an eye on the affected side. Facial droop, difficulty with facial expressions, facial stiffness. There might be some pain, headache, taste might be affected. It's facial palsy. It resolves itself for the most part. I'm not sure if there's any other real treatment other than watching and waiting.